So when we're talking about lochia, we want to know how much the patient is bleeding. So we are going to refer to it in terminology of scant, light, moderate, and heavy. And you can see a visual example here of what scant looks like, light, moderate, and heavy. And that has to do with kind of a standard size peri pad. In labor and delivery, it's a little bit of a different situation, although we utilize that same terminology. But this is what, in our postpartum assessment, this is what we are looking for. So scant is very little. You can see light, moderate, and heavy. Now, we're going to be concerned if they are bleeding heavily. So if they're completely saturating a pad within an hour, then that's going to be concerning to us, and we're going to need to intervene in some way, shape, or form. Typically, just massaging the uterus is all we need to do. So after lochia, we're going to take a look at the episiotomy and laceration. And from order perspective, so I said we were going to look at the bum. So while we are looking at the bum, we are also looking at the lochia, because that's where the lochia is, right? And we also want to, or that's where their pad is. We're going to take their pad down and take a look at it, and have them roll over and look at their bum and make sure there's no bleeding that's gone behind the patient, because that can happen to where they're bleeding and it goes back. And you look at the pad and it looks scant, and then your patient passes out, you move them, and they're sitting in a huge puddle of blood. So we want to make sure that we are looking behind the patient, and just having them roll over to the side to look under them is perfectly adequate. And we can do that while we're looking at their bum to make sure there's no hemorrhoids, and we're looking at their laceration or episiotomy. Or repair, I guess we could call it, to be all-encompassing in the postpartum period. So we're looking at the repair to make sure that it looks good. We want the sutures to look okay, make sure it's approximated. You can assess it like any other wound for REDA. So REEDA, redness, ecchymosis, edema, drainage, and approximation. For our H, we're looking at a Homan sign. So Homan sign is kind of we still utilize it sometimes in OB. Some places do, some places don't. Tri-City still does, but we're not going to massage the calf. We're just going to ask if there's pain upon flexion. We want to check for clonus and DTRs while we're there, because that can indicate neuromuscular hyperactivity, which is present in our preeclamptic patients. So we want to make sure that we are assessing that while we're assessing their legs. When we're talking about emotions, you can see these Rubin's psychological changes of the puerperium, which means a mom, essentially, after birth. And first, she's going to be taking it in. She's willing to let others do things for her. She's going to want to tell her birth story. She's going to kind of accept help, and then she's going to take hold, and she wants to be the one doing everything. And then they'll slowly settle back into a lifestyle that now involves a new baby. But one of the things that we really want to make sure that we're addressing, and make sure we're addressing it in front of significant others or whoever's going to be at home with this mom, is postpartum depression. So baby blues as an emotional state after birth are totally normal, and it's for the first couple weeks, and it's just emotional up and downs. I mean, this woman, first of all, her hormones are completely out of whack, and then she's not sleeping. She's probably not feeding herself very well. She just went through an incredibly exhausting event, if not an incredibly intense one too. And now she's trying to feed a baby. So her, she can be crying one second and laughing the next, and that's totally normal. It's not really normal if it extends past that second to third-ish week, or if she ever wants to cause harm to somebody else. So that's why we really want our the people at home to be aware of these signs and symptoms as well for postpartum depression and even postpartum psychosis, because they might notice it before she does. And postpartum depression is very serious. We can treat it though. Postpartum psychosis is, those are the women who, drive their car full of children off the cliff. And that's a progression from depression to psychosis. And it can go pretty quickly or it can take some time. So we want to get these women treatment when it's early on. So here's some great things for breastfeeding when you are helping a mom breastfeed, because you will help a mom breastfeed in postpartum, is we want mom to be relaxed. We want mom to be comfortable. Mom and baby should be belly to belly. So that means that the baby can hang down a little bit and be closer to mom's belly. And more of a C presentation. So we want her arm to be kind of in a C. We want the lips rolled. And if you look at me real quick, if you want the lips flanged like that, because if the lips are tucked like this, the baby's not going to be able to fully accept all of the breast tissue, and they're going to end up just sucking on that nipple. The nipple is just a delivery device. The nipple does not have the milk in it. It does not produce the milk. It does not do anything except deliver the milk. So we want the baby to put as much of the breast tissue in their mouth as possible. So your lips really need to be flanged out. And then their tongue comes out too, and it can make that's how they suck. And we want them nose to nipple. So that's going to be pretty much the perfect alignment to get that nipple to go where it needs to go in the back of the throat, is nose to the nipple, and then the nipple will be facing up at that point. So some of the baby things that we're going to be doing in postpartum and in labor and delivery is we might be asked to feed a baby. Some moms choose to formula feed, which is their prerogative. And some babies we need to feed because their blood glucose is low. So when we feed a newborn baby, we're going to want to make sure to tilt the bottle. We're also going to pour out the majority of it. So our little formula things that we get at the hospital have 100 mLs in it. The typical feeding is between 15 and 20 mLs. So we don't want that whole 100 in it, because the baby will just gulp it all down and then spit it all back up. So we were going to dump out the majority of it and leave about 30 in there for the baby to drink. And then we're going to make sure to keep an eye on how much the baby eats. And you can see the positioning here with the baby slightly tilted, or the baby slightly elevated and the bottle tilted. After we feed a baby, especially a bottle-fed baby, we're going to want to burp the baby. We will practice diapering when we're in the skills lab, and any blankets need to be swaddled around the baby. We're not going to just lay blankets around the baby. And we will put hats on the baby. We put a hat typically right after birth, and then they get a cuter hat a little bit later, typically. For the bulb suction, those are those round with the long tube that you can utilize in the nose or the mouth. We use those right after birth to stimulate the baby. We also always have one present in the crib in case the baby starts to choke. So the baby is going to have a lot of secretions that they're working through, and they might need a little help getting some of those out. So if we see a baby coughing or anything like that, we're going to use that bulb syringe. It's also going to be one of our first go-tos if we do need to resuscitate a baby. Say you walk in the room and the baby, because mom hit the call light, was like, my baby stopped breathing. That's our first go-to, is the bulb suction. Tripping over my own words. It not only stimulates the baby, but it also helps to remove anything that might be causing that difficulty. So when we hold a baby, we're going to want to make sure that we're supporting the baby's neck. Babies don't have any muscles in their neck, really. So we want to make sure that we're always supporting the baby's head and neck and not letting them just flop on back. Most of the time they'll be swaddled really tightly, and that's not too much of an issue. But when you pick a baby up, you just slide your hand right under the baby's neck and pick the baby, under the baby's head and neck and pick the baby up. When we transport babies, they need to be in the crib, which has wheels, and we transport the baby, pushing the baby down the hallway in the crib. And it's a safety thing, so that we don't, if we see somebody walking down the hallway with a newborn in their arms, we all know to stop and ask them and to stop them in general, because there might be an infant induction situation going on. As for pacifiers, the hospital does have pacifiers. We highly recommend that patients don't utilize pacifiers until at least 2 weeks if they're planning to exclusively breastfeed. The reason being is because, one, the baby wants to suckle so much to bring mom's milk in. So if we're utilizing that non-nutritive sucking, then we're not bringing mom's milk in, and mom's not going to produce quite as much milk, because milk is supply and demand. The other thing is that the baby's going to produce a nipple preference. It's much easier to suck on a pacifier or even on a bottle than it is to nurse from mom. That takes a little bit more work, especially in those early days. So we just always recommend that people wait until about 2 weeks after. There's definitely some exceptions to that, though. So it's not a hard and fast rule. But if somebody requests a pacifier from you, talk to your nurse about it before going to the storeroom and getting them one, okay? Or me. We'll chat about it. So for the newborn assessment, as the newborn, so there's 2 different newborn assessments that you're going to be doing. There's the newborn assessment that's directly after birth, and that's going to include this neuromuscular Ballard score that is down here. And then there's the newborn assessment that is the standard newborn assessment. That's the head to toe. And you can see here, we don't want to disturb the kid. So we want to get the respirations and heart rate while they're calm and quiet. Now, some babies just are not going to be calm and quiet, and we do what we can. But if we can get the respirations and heart rate first, then we can actually hear really well. Babies' heart rates are fast. And in skills, you'll have the opportunity to listen to a baby's heart rate and practice counting it, because it takes some time to get used to that. We'll want to take the temperature before fully unwrapping the baby, and we're going to use an axillary thermometer, and it goes vertical, so it goes like the length. You're going to place it like this, boop, and hold the baby's arm down. That's going to piss them off, so do the respirations and heart rate first, because they're going to start crying when you do their temperature. And we're going to take a look at their head. We're going to feel the baby's head, feel the fontanelles, make sure they're soft, and we're going to feel the suture lines, feel the back of the head, and you can take a look at the checklist that's listed in survival skills and it's under clinical on Canvas to see exactly how this proceeds. We're going to take a look at the facial symmetry. We're going to look for any hematomas. We're going to take a look at the scalp symmetry. We're going to look at any capit or any abnormalities on the scalp itself. And we'll put the cap back on, the little hat back on, keep the baby's head nice and warm. We're going to take a look at the eyes. We're going to make sure the eyes are nice and clear. We're going to take a look at the ears. We're going to pull the ears down and let them pop back up. That has to do with Ballard score, but it's what we'll do when we're assessing them. We're going to look at where they align too, because that can tell us whether or not this kiddo has some sort of syndrome. We're going to look at the nares, which isn't on here, but the nares, we're going to want to occlude each nostril and make sure that the baby can still breathe, because babies are obligate nose breathers for the first few months of life. So we want to make sure that they don't have a deviated septum situation, which is going to prevent them from breathing through one nostril or the other. When we proceed to the baby's mouth, we're going to take and run a finger into the baby's mouth, and we're going to feel and make sure that their palate is complete and that it's not any sort of cleft lip or cleft palate. The other thing that we're going to do when we have our fingers in the baby's mouth is we're going to let the baby suck on it, and we can assess the baby's suck at that point as well. And we're going to move down and we're going to feel the baby's clavicles. So we're going to just press on the baby's clavicle and make sure it feels intact, that there's no crepitus. Birth can be pretty traumatic, and sometimes the clavicle does get broken. So that's why we're assessing that. As for the Ballard score, the neuromuscular score, this is on that checklist that you have under clinical. We look at a couple different things. We look at what's called the scarf sign, and you can look at that, the square window, the heel to ear, and the popliteal angle. So those are the main ones. We're also going to look at the breast tissue of the baby to see how developed it is. And those all give us a clue at the true gestational age of the kiddo. We're going to turn the baby over then and take a look at the back. So we're looking to see if there's any birthmarks like Mongolian spots. One of the reasons why we really look at this point is because Mongolian spots look like bruising. So we want to make sure that we're pointing them out to the parent and saying, hey, look, your baby has Mongolian spots. It's a common birthmark that fades over time. And that way, when they look at that later, they don't think, oh my gosh, that nurse bruised my baby's back. So that's one of the reasons why we're really looking for it at that point in time, so we can show the parents and point it out. We're also going to take a look at the spine. I'm going to feel the spine and make sure it's nice and straight. There's no masses or lesions. And we're going to look for the sacral dimple. So sometimes at the point where the spine reaches the sacrum, there could be a dimple, which could be indicative of some degree of neural tube defect, which would be spina bifida. When we turn the baby back over, we're going to take a look at the baby's cord. We want to make sure that there are two veins and one artery, and that everything that it looks good. We're going to take a look at the genitalia. We'll assess the male genitalia to ensure that the testes have both descended, and I'll show you how to do that in the survival skills. And some of the reflexes that we're going to assess for, I already talked about the suck reflex. We're going to assess for the Moro reflex, which is the startle reflex. So the baby startles. We're going to assess for Babinski, and we're going to look for the rooting. So we stroke the baby's mouth and the baby is going to move this way. So those are some of the main reflexes that we look for. There's a few others that we can do, but those are the main ones that hospitals are looking for. So newborn vital signs. So we want an oxygen saturation, and this is after the first 10 minutes of birth. The first 10 minutes of birth are a little bit different, but in the newborn situation, typically, we're looking for an oxygen saturation of more than 95%, temperature between 97.7 and 100.4. Respiratory rate is 30 to 60, and a heart rate can range anywhere from 90 to 180 in a newborn. Our fetal heart rate normal range is 110 to 160, and that's typically more what we see in the newborns, but normal is 90 to 180. Some things to keep in mind for our little ones is the 3 hypos. So hypothermia, hypoxia, hypoglycemia. So if our baby gets cold, we can lead to the baby not having enough oxygen and the baby not having enough blood sugar to adequately support brain functions. So we want to keep our babies nice and cozy warm, which is why you'll see a lot of them having like a double wrap and the cap on. But if we have a baby under the warmer, we're going to be very cognizant of how warm that baby is, because we don't want to get them too hot either. When we bathe the baby, if you have that opportunity in postpartum, we're going to take a temperature beforehand and make sure that that baby is nice and cozy warm before we bathe the baby. And then we're going to do the bath typically under a warmer. And then we're going to take the baby's temperature after the bath and make sure that they were warm enough. One of the best places for a baby to thermoregulate is skin to skin with mom. So unless we have a baby that has something else going on, some abnormality, placing baby skin to skin with mom is the best way to warm a baby up. And if you ever are taking a temperature or blood pressure, or I suppose would be the main ones, but if you're taking a temperature or blood pressure and your machine is not reading, it's probably because what it's reading is so far out of the range of what the machine programmed that it can't detect it. And for babies, it's typically because they're really cold. So just kind of keep that in your mind, that if your thermometer is not taking that temperature, touch and feel that baby and see, does this baby feel cold? Maybe this baby is really cold. All of our newborns are going to have a hearing test before they go home. And this is really important because it identifies issues that might be there that we want to take care of as soon as possible. So the hearing test will take place again before the baby goes home. This is a good little picture of the umbilical cord. So you can see we have the umbilical artery and the veins. And this is what the umbilical cord looks like, a real live umbilical cord. So we're going to clamp the cord, and then we would have daddy cut the cord here. We would actually put another clamp, an Alice clamp on here, and cut in between them so that we don't have too much bleeding from the placenta out of the cord. Obviously the baby's not going to be bleeding, but the placenta just saves us a mess, essentially. Security bands and alarms. Tri-City actually doesn't have any, like they don't have the hugs tag or the kind of the baby low jack system. However, they do have the baby bands. So you will see that the nurses all verify the bands. And when we transfer care, we verify bands and make sure that the mom's band matches the baby's band. It's very rare that the baby gets taken out of mom's room at all. However, if that does happen, you would definitely check that as well, but we still check upon transfer. As for cord care, we recommend that parents not use any alcohol or anything on the cord. They should just clean the area kind of with a wet washcloth. They can use a little bit of a really mild soap if they want to, but the cord will dry out and fall off within the first week or two. And we don't want any alcohol on the cord before that point at all. Here are some musts. You must wash your hands. So newborns have no immunity. Remember that. They're born with virtually no immune system because immunity is acquired and they haven't had the opportunity to acquire anything. So washing your hands is key. Until that baby has been bathed, you need to wear gloves when you're touching that baby too, okay? And you can ask the nurses in postpartum if they have a special way of denoting when a baby has been bathed. They've changed the process there a little bit recently, so I'm not familiar with it. I will ask too, but if you get to it before I do, then just again, you don't want to touch a baby with bare hands unless that baby has been bathed. We talked about the baby band checks. As for feeding, babies need to feed every 2 to 3 hours. They can go one long feeding or one long stretch of time, probably about 4, maybe 5 hours, but more 4. And so we recommend that the parents feed every 2 hours throughout the day so that they can get that stretch at night when they want to sleep as well. For the first couple days, we're going to be recording I's and O's. How do you think we record I's and O's on a baby? Well, we have a couple different ways. We can weigh the baby before a feed and weigh the baby after if it's a breastfed infant. If it's a bottle-fed infant, we can see how much formula that baby ate. And for O's, we're going to do counts. So we are going to, in a NICU situation, you're going to weigh the diapers. In a pediatric situation like pediatric ICU, you're going to weigh the diapers. In a normal newborn nursery care or normal couplet care with a newborn, we are just going to do counts. So we want to know how many pees and how many poos each day. And they should have the same number of poops as they are days old, up to probably about the first, I think it's 5 days. I think 5 poops a day is the number we're trying to reach for there. So, and so much of postpartum care is about teaching. Moms are overwhelmed, so we have to tell them the same thing over and over and over again so that they actually hear it and they go home with a little bit of comfort and that they know what to do. So we're going to teach. We're going to teach about breastfeeding. We're going to teach about baby care. We're going to teach mom about her own self-care. We're going to teach her about what she can expect from the baby and going home, and tons of information. We're going to sit and let her ask away. And that's where the postpartum nurse spends a lot of her time, is teaching her patients. So I hope throughout this you are writing down any questions that you might have, and we will talk about those on Monday during survival skills, and we'll get to practice. So you'll get some hands-on time.